what are most people thinking about when they think about peptides? So this is one of those diagrams that marketing people use to look for what's happening and why we're using what people are looking for when they're talking about peptides. And so lots and lots of patients are looking for lots of things about peptides. There's a lot about skin, cancer, weight loss, fatigue. And so there's lots of things out there. But what are doctors thinking about when they think about peptides? Get myself oriented here. Of course, but most doctors, when you talk about peptides, or providers in general, when they talk about peptide, think about growth hormone. And so this is where you'll start. And of course, it's called the youth drug in a lot of situations, and lots of people use it. And there are alternatives available, of course, sermorelin. And then what we have to understand is that peptides are signaling molecules. So these are, for those of you who aren't familiar, these are small proteins. Proteins are considered any sequence of amino acids greater than 150. The peptides are considered anything less than, I guess it's now 43 officially, but less than 50 is what I was originally taught. And these are signaling molecules in the body. They do all kinds of things. They bind to hormones, they bind to receptors and cause things to happen inside the cell. In 1902, we started with learning about secretin, which is one of the peptides that is secreted from the duodenum. It maintains water balance and secretes bicarbonate to help with digestion and absorption and modulation of the immune system. So that's quite a long time ago. Substance P soon came along after that as a intestinal contraction and vasodilator. Now we've, of course, learned about this being involved in neuropeptides as far as pain modulation goes. In the 50s, we learned about oxytocin. Of course, most people are familiar with this for women with contractions during or postpartum, and then also the appreciation of babies and sexual intimacy and reproduction. So then in the 50s also, we decided, or were able to come up with a way to do solid phase synthesis. This is a much more efficient way to create peptides, binding them to one amino acid at a time to a resin, so that these were much easier to create rather than having to collect them from pigs, or such, as you know, from insulin in the 60s. Historical problems, of course, they are weaker, and they have lots of course, in your body, they have enzymes designed specifically to break them down. So they quickly go away. They have a very short half-life. They're usually not orally available. And then there is a possibility of the development of immunogenicity or antibodies against these peptides. The positives about this are, of course, that they're effective. They're very effective. They're highly selective. They bind directly to the receptor itself, and they are very potent in their specific drug, specific action. They have a predictable metabolism. They're typically shorter to market, and when you are able to get them to an FDA approval, they have lower attrition rates. They're actually able to go more quickly than small molecules actually to FDA approval. Here's some examples: losartan. Some others you may have heard of. Both of the angiotensins, angiotensin 1 and 2, are common small molecules. They are things like bacitracin. I didn't realize when I first started studying about this that bacitracin is actually a small molecule. So I use this when I'm talking to patients, and I say, these are not scary new things. These are things that we've known about for a long time, since the 1920s, and it's familiar things to you like angiotensin, insulin, oxytocin, and bacitracin, stuff you're already using. There's, of course, a current explosion in peptides, and although the synthesis is fairly new, we have created better ways to stabilize these and increase their half-life. We know about their targets better. We can do computer modeling to see what receptors might be needed to be modified, what peptides would be effective at that receptor, and now we can get better at creating the peptides themselves. This is continuing to arrive. Many are approved by major pharmaceutical markets. If you're familiar with the more recent liraglutide or semaglutide, and there's others in that group, I forget the last name, dulaglutide, I think. And then the new group class of migraine medications that are CGRP agonists. this is coming out and they're effective, and people are finding out that patients don't actually mind using them when they're effective, because they are so effective and the side effects are pretty minimal. You can see that the greatest amount of peptides being created are in the oncology and metabolic medicine areas, and this is just specifically because of their ability to their specificity and their efficacy. We go on. Again, what peptides are being developed between 2000 and 2009? Of course, it looks like you can see how metabolic, oncology, and cardiovascular were our biggest areas of development. And so let's go on to talk about immunity and immunosenescence. So I want to talk just a little bit of background, that there are two systems of your immune system. One is the innate immune system, the other is the adaptive immune system. For a second, I'm going to talk about the innate immune system. In your blood tests, you look at this as your monocyte, eosinophil, and basophil count. In my regular visits with patients, I will sit with them and measure, I'll go over their MEB, add the three of those together. If they're staying under 10, I'm super happy. If they're between 10 and 15, I start to get worried about inflammation or infection. I look at their dental health, I look at their intestinal health, their prostate health, trying to figure out where their MEB might have increased. And then if their MEB is greater than 15, I may consider going ahead and treating them for infection or autoimmune disease without a specific location, because it's just such an expression of innate immune response. This system responds to these pathogen-associated molecular proteins. And so on the outside of the cell, these PAMPs, DAMPs, and MAMPs, and there's other things, there's LAMPs too, they all are pieces of cells or pieces of bacteria that stimulate the cell to begin to panic a little, that something's happening. It's sort of like the barking dog in the middle of the night in your backyard saying something's wrong and we need to pay attention to it. So it starts to create this inflammatory reaction wherever this occurs, this attachment of the PAMP or DAMP or et cetera to the toll-like receptor. Those cells now begin to react in this inflammatory way, and the tissue begins to become inflamed. The problem with the innate immune system, and you guys have probably heard about this on television and the news, where we begin this with coronavirus, where we begin this excessive or protracted signaling by this immune system. So that barking dog that just continues to bark throughout the night. Now you're not sleeping. Now your next day is ruined. And as this begins to happen, we see that people begin to develop disease states. And so these pro-inflammatory cytokines that are produced by these stimulated cells now have this amplification of this immune inflammation going on. And now we begin to skew development of these naive T cells away from treating disease, and now they're creating disease. So the macrophage is the cell of the innate immune system. It activates in response to injury and illness, as I just mentioned. It begins to generate these reactive oxygen species. When we talk about acute inflammation, this is healing. So you cut yourself, it turns red, you get a little irritation of that area, it heals up, goes away, everything's fine. Chronic inflammation can lead to cellular death, and this is what we want to avoid in most of our disease states. These macrophages, these innate immune system cells are activated in the presence of aging, neurodegenerative disease, migraine, mood disorder, concussion, kidney disease, cardiovascular. This is why we need to be paying attention to this, because it's involved in all of these phases and all of these disease states, plus many more I didn't even mention. If you just do a Google Scholar search for macrophage and whatever disease state you're studying, you're probably going to find it. And so the microglia are the macrophages of the brain and the nerves. And so you can see here they're activated by these PAMPs and DAMPs. And they have the chance to change their shape or their expression. So rather than being this nice janitor that takes the trash out, this M2, as you see on the right side of your screen, producing anti-inflammatory cytokines and nerve growth factors like BDNF and NGF, Instead of that, if you're stimulated, if the microglia or the macrophage is stimulated by PAMPs or DAMPs or other environmental problems, is estrogen deficiency, for example, is one thing that can stimulate this. It can convert into this M1 phenotype. So now it begins to secrete these pro-inflammatory cytokines or chemical messengers, as you see, IL-1, TNF-alpha, IL-6. And now this M1 phenotype expressing henny cell is creating this inflammation in the area where it's located, and it can create disease states like neurodegeneration, as I mentioned in the previous slide, other disorders. The innate immunity is on the left, and then the adaptive immunity is on the right. There is a symbiosis between these two. One stimulates the other to develop, and so you stimulate the B lymphocytes, and now you create antibodies. You stimulate T lymphocytes, and now you create effector cells that can kill viruses, that can affect cancer cells, etc. The thymus gland is a gland that produces throughout your life thymosins. These are biological response modifiers. They are endogenous peptides. They stimulate the development and differentiation of T lymphocytes, which I mentioned in the previous slide. They regulate the immune system and stimulate other cells as well. So they're not limited to T cells. Several factors control the release of these peptides: foreign bodies, pathogens, chemical messengers and signals, pituitary and other hormones, estrogen included, and nervous system stimulation. What is immunosenescence? The immune system undergoes a specific age-related alteration, and this accumulates and auto-amplifies, producing progressive deterioration over the lifetime. Now you have a decrease in ability to respond to infection and an increased risk of developing immunity after vaccination or exposure to illness. And both of these are associated, as we've unfortunately discovered in the last year, particularly, or 3 months particularly, the higher rate of mortality in the elderly. This condition is specified by unique things like reduced natural killer cytotoxic potential, decreased phagocytosis or engulfing or eating of pathogens by your neutrophils. The macrophages decrease anti-inflammatory cytokine production. The dendritic cells reduce their interferon production, and all of the immune cells have specific things that they decrease in ability to do as we age. These are predictable changes that occur in the immune system with age. Again, similar, you'll see a dysregulation of the pattern of recognition. You'll see decrease in phagocytosis. You'll see people have talked about inflammation, which is this chronic low-grade inflammatory status. We relate to a lot of infections that we accumulate over lifetime, in decreasing in the T cell repertoire, the presence or the number of naive T cells, and we get thymic involution, which is conversion of normal thymus gland cells producing T cells and thymosins also, and replacing that tissue with adipose. This thymic involution is responsible for the inability to replace naive T cells. They are used up by exposures over the lifetime, and this predominantly occurs, I think, interestingly, around the time of puberty. So this thymus gland is designed to get you to the point where your body is able to reproduce itself, and then it begins to decline in function, at which point you are now susceptible to infection, cancer, etc., because of the decrease in immune function. But the body evolutionarily doesn't care about that because you have passed your reproductive age, which was its goal. And so then we talk about some treatment targets. If we're talking about inflammaging, we talk about some treatment targets. If we look at the thymus gland, because we see these specific changes and the thymic involution that we just talked about, growth hormone therapy, as you will see, is one of the things that we can do to reverse this thymic involution. We can also give thymosins themselves if thymic involution has already occurred. The disease damage that occurs with, or the immunosenescence that occurs to neutrophils specifically, there is a potential for DHEA to be beneficial in fixing this phagocytosis and the reactive oxygen species production. CD4 cells, as they become unable to do things, you can also fix them with using growth hormone, as you will see. And so DHEA is a treatment option. The high rate of infections after hip fracture may be the result, and this is a study that was done, maybe the result of this neutrophil dysfunction. And so we have a specific human study relating hip fracture and infection to the immunosenescence. DHEA has the opposite effect. We know that the ratio of cortisol to DHEA in elderly or ill patients is predictive of their outcomes. Even in young trauma patients, that cortisol level being the cortisol to DHEA ratio is predictive of a poorer outcome. This DHEA is markedly reduced with age, and so the effect of cortisol will be seen particularly in our elderly after injury. Think of our geriatric patients with falls. This may be related to why they do so poorly after that. We also see that supplementing with DHEA can enhance production of antioxidants and increase natural killer cell activity. So let's talk about growth hormone in immunosenescence. So given the circumstantial evidence that declining circulating levels of growth hormone coincides with thymic atrophy, we believe that this is one of the causes of thymic involution. And we know that if we give people growth hormone or insulin-like growth factor, IGF-1, we know that we can stimulate thymopoiesis or regeneration of the thymus after involution. Some concerns, of course, about growth hormone-induced high insulin, that this is undesirable and may affect that thymic regeneration. So you're getting sort of a counterbalance by giving them growth hormone, but unfortunately they're getting high insulin, so the thymus doesn't react. And so there is lots and lots of justification for using growth hormone to regrow thymic tissue. And we know that the thymic cells express growth hormone receptors, and then they secrete growth hormone in a feedback loop so that the higher production decreases its production. It's feedback loop. If we look at the TRIM study, combining growth hormone with DHEA and metformin, we feel like this combination may limit that hyperinsulin that occurs. There's a study by Fahey, y'all have probably read it in 2019 from last year, reversing aging by 2 years. And so the combination, that was the reason for this, considering this combination. It is a calorie restriction mimetic and stimulates AMPK in aging mice. Of course, there is some question, in my mind at least, about how it works, because I understand it works on the cytochrome of your mitochondria. And of course, I don't really, as an athlete, I don't have any desire to affect my mitochondrial function, so I'm guarded about that. And I can talk about, at some point, my favorite peptide instead of metformin. So again, this is this cocktail does partially restore the atrophied thymus, and I'll give you more information about that when we go and talk about them later. Treating 9 patients for 12 months, the thymic-free, fat-free fractions. Remember, I said that the thymus gland is replaced by fat. After we see this fat fraction decrease in most of the cases. And the cases that didn't respond, that it says 7 out of 9, well, the 2 cases where it didn't respond, they had a fairly low thymic fat fraction to begin with. So that's pretty interesting, I think. Then we also see changes in their immune response, in their monocytes that are CD38 positive, and in their lymphocyte-monocyte ratio. And this lymphocyte-monocyte ratio is something I use also in my patients right now to determine aging or degree of illness. And my goal is to get them above 6. So this is a simple test you do, just a CBC, $3 from Quest or LabCorp or whoever you use. And we can see that this lymphocyte-monocyte ratio greater than 6 does it restore thymic function, at least in this study. And because growth hormone acts predominantly through induction of growth of IGF-1, they were trying to be sure that this didn't accelerate aging or cancer, and they looked at PSA. There was no signs of increase. In fact, there was a decrease in PSA. And then they also looked at these various epigenetic clocks, which look at the methylation at specific DNA sites. And based on what we know about methylation of DNA, we can predict life expectancy, and the rates of decline in age increased, and they persisted for at least a year. I think that was. I have a little bit another slide later. After the subject stopped the treatment protocol. And it is interesting that growth hormone and DHEA are things that decrease with age. So replacing them may be the reason for why this works. Another thing I use for monitoring patients' aging is their serum albumin. And you can see it's associated with long-term mortality in readmitted medical patients. In this 54,000 Veterans Medical Administration study, they had serum albumin preoperative that determined their outcomes. And again, the goal of all of these seems to be around 4.5. So I've been watching my patients on their plain old CMP that you get on everybody pretty much. I watch their serum albumin, and that's a good predictor of their overall health as well as their aging. Of course, this is not a single test in time because lots of things affect a single test, but monitoring over time the progression of their serum albumin. And then the biological age, we talked about the epigenetic age, and that methylation is a very specific marker of aging. We can talk about that on another, I think we're going to talk about that in the module 4, 3 or 4. But anyway, the epigenetic age is valuable test, and of course, especially as we begin to try to do these anti-aging therapies, that would be valuable. We know that reducing the aging rate by 7 years, you reduce morbidity by 50%. So that just makes sense. If I can improve people's aging rate, I should be able to improve their cancer, their risk of diabetes, their risk of all sorts of diseases of neurodegeneration of aging. The thymogens were discovered in the 60s, around the time when we came up with solid phase synthesis and insulin production. And then these are a family of biologically active peptides with hormone-like properties. They are small. They have important clinical applications. They stimulate or suppress the immune response. They regulate actin dynamics and cellular motility. They affect neuroplasticity, repair and remodeling of vessels, and stem cell differentiation. Thymosin alpha-1. This was first used in a clinical trial in 1985, so this has been around for a long time. It has lots and lots of research. Again, Google Scholar, thymosin alpha, and there's tons of articles. I put a lot of them in, links to a lot of them in here. This is a hormone that's secreted by the thymus. It stimulates T cell production, development of B cells, and antibody production from those B cells. In vitro, it increases the production of anti-inflammatory cytokines. It inhibits inflammatory cytokines. It differentiates T cells. It increases the ability of the cell to demonstrate it's infected. These tumor antigens on the outside of the cell, so it also allows the cell to say to the immune system, hey, there's an infection, hey, there's a cancer, and so now the immune system can respond to the presence of that. It also increases glutathione, which we know is our #1 antioxidant. Thymosin deficiency is part of that thymic involution and aging. And symptoms of deficiency, who doesn't have a patient with fatigue, lack of motivation, physical exhaustion, chronic infections, slow wound healing, joint pain and injury, or development of cancer. And signs of thymosin alpha-1 deficiency are CRP, fibrinogen, sed rate, and a low CD4 to CD8 ratio. It is a 28 amino acid peptide derived from pro-thymosin alpha. It has immune modulating properties, as I mentioned. It is known under the brand name Zidaxin and is FDA approved with orphan drug status. Currently, it is in phase 4 clinical trials for hepatitis B infection. How would I use this? Epstein-Barr virus. I have several patients with Lyme or mold or chronic fatigue, maybe related to Epstein-Barr. I use it in any of my cancer patients. Hepatitis, including infectious and autoimmune and alcohol related. Any autoimmune condition, the flu or a cold, and I'll give you that protocol a little bit later. I use it in my elderly patients if I'm giving vaccines, which I know that's a whole other conversation, but if you're giving vaccines, it does help the body respond appropriately to that vaccine. And then as a general senolytic or anti-aging therapy. It directly suppresses viral and tumor replication, but it also increases, as I mentioned, the cell's ability to express antigens on the surface, making them more susceptible to immune destruction. So its direct effects, it's suppressing viral replication, and then it's indirect on expression of viral antigens on the outside of the cells. So now they're less prone to escape. If you're familiar with treating Lyme disease, these patients have cells, the Lyme goes into the cell and escapes the immune surveillance. The thymosin alpha-1 will restore that major histocompatibility complex on the outside of the cell, expressing so that now the immune system can attack the cell. Here's a picture of everything I've just said, the effects of TA1 on dendritic cells, T cells, natural killer cells, and cytotoxic T cells. In this study, in patients with chronic hepatitis C, you can see it increases that Th1 subset of T cells, which are the anti-inflammatory cells. You can also see in the in this mouse study with herpes simplex virus, it also increases natural killer cells, which have direct cytotoxic effects on virus-infected cells. We know that immune dysfunction is associated with all of these disease states, and many more that I did not even include in here. We know that your immune system flips from this Th1 to Th2, and you develop all of these disease states. So this is where we're going. And I hate to say that TA1 is this all-encompassing peptide, but I really feel like in my practice it is. And in many cases, I can't treat the patient until I've given them TA1 with any other peptides or any other immune modulating or even weight loss, all of those things. I'm going to treat them with TA1 first, because sometimes they can't respond to anything else until they have that TA1 in place. And so with the thymosins, we ask, is this that immune dysfunction is a key underlying cause of many of our age-related diseases? And I think the answer with the research that you'll see or have seen is yes. And then can we modulate this immune system with thymosin peptides and successfully treat both illness and aging? There are studies on clinical effects in Lyme disease, chronic fatigue, and fibromyalgia, reversing the immune suppressive effects, as I mentioned, about Lyme disease, and conversion of IgM to IgG. It has antifungal properties. It increases antioxidants like glutathione, directly inhibits viral replication, increases the viral antigen expression. And then when you give patients steroids, that increases that involution of the thymus, the apoptosis or programmed cellular death of your cells of the thymus gland. And so if you give patients, let's say you give them a cortisone shot for whatever you're giving cortisone shots for, you giving them thymosin alpha in addition can block that steroid-induced apoptosis of your thymus cells and help them to maintain their immune response or appropriate immune response. There are clinical effects also in eczema, asthma, rheumatoid arthritis, inflammatory bowel disease, and you'll see that thymosin alpha-1 works differently in different tissues depending on what's needed. So it is a very smart peptide. And these are great articles. I love this Romani article if you get a chance to read that. So take some time and come back and look at these. MS, if you take the peripheral blood mononuclear cells from MS patients, the relapsing remitting type of MS patients, and then you expose those cells to TA1, we know that their endogenous TA1 was significantly lower than in controls. We know that if we can increase the production of, that if we give them TA1, that we decrease production of inflammatory factors. So we pre-treat these peripheral blood mononuclear cells with TA1, they drastically, in fact, decrease their production of inflammatory factors. And then they upregulate IL-10, which is this potent anti-inflammatory and immunosuppressive cytokine. So that it does this in just the perfect balance. So you're not blocking, you're not completely suppressing the immune system. You can still respond, but you are getting rid of that excess amplified response to an invader or a damage or trauma. Neuroproteinopathies, this is sort of the buzzword now for things like ALS, Huntington's disease, and other protein disorders of the brain. This is a rodent study where they did an intraperitoneal or systemic injection of TA1. And in these patients, they have glutamate becomes an excitatory toxin, and their glutamate transporters are destroyed. And so we know that, are highly upregulated. And so we know that if we give them TA1, we can decrease this glutamate excitotoxicity. We can decrease production of these inflammatory cytokines. And so we know that it can be used, again, in infectious disease, immunodeficiency, chronic inflammation, cancer. It functions by modulating the immune system, and specifically through the innate immune system. And then that reactive, remember the henny penny versus the janitor microglia or monocyte, in this study, after just 3 days of treatment, it inhibited the reactive state, that M1 inflammatory state of the microglia. It went back to that M2 or janitor, clean up, tidy, put things away in drawers where they're supposed to be kind of cell. In autoimmune thyroiditis, lots of you probably treat Hashimoto's, and these are mice that were injected with thyroglobulin and lipopolysaccharide. They were given 5 or 10 milligrams daily sub-Q injections in various doses. I'm sorry, they were given 5 to 10, not milligrams, 5 to 10 daily injections, poor little mouse. And these are the doses. And they gave them at various intervals, and they found that it suppressed the thyroiditis that can occur due to lipopolysaccharide and thyroglobulin. So what we're saying as far as the extrapolation to human patients is that, that we use this in my practice in autoimmune thyroid disease, and I don't give it 5 or 10 times a day, of course. I give it typically if they are in a current inflamed state, I'm going to give it daily until they decrease their inflammation, and then I'm going to decrease to every 3 days. You'll see that protocol in a minute. There are lupus trials show clinical and chemical improvement, not just I feel better, but also we see their SED rate and double-stranded DNA titers go down. In COPD, we see giving them thymosin alpha-1 decreases the exacerbation frequency, that it increases the effectiveness of vaccines given to elderly men. In patients with cystic fibrosis, it increases the the mutated protein maturation. So these patients have a mutated protein that causes a lot of disease, that causes their disease state, and it increases the maturity, stability, and activity of that protein, so it's not left to gunk up the works in the cell and cause more inflammation. In patients with severe sepsis, these are ICU patients. These are all these are human trials at the 1.6 twice a day for 5 days, then every day for 2 days. They had improved outcomes, faster return or faster relieving the ICU. And then they can use them in conjunction. You can use this in conjunction with pharmaceutical immune modulating therapy. So for example, in some of my Crohn's or colitis patients, I'll use this in conjunction with them to, for example, they might be on some of the immune modulating drugs. I think I can't say them because of CME, but you know what I'm talking about. And so I can use them at the same time, and then we get their immune system to calm down, and then I can wean them off of, and we've been able to wean them off of their immune modulating therapies from pharmaceutical immune modulating therapies. In chronic hepatitis B, we know that chronic hepatitis B is associated with lupus, rheumatoid arthritis, diabetes, MS, etc. In this study, there were 12 patients who had chronic hepatitis B for at least 6 months. 7 of them were treated with TA1 twice a week. Their liver enzyme levels significantly improved. 86% completely cleared their hepatitis B. The replicative forms were only present in 1 of 7 treated patients. They showed improvement in their inflammatory T cell counts. They had no side effects, and these effects were sustained for 26 months after treatment. So I thought this was really impressive, even though it's a 1991 study. The pathogenesis, much like what we've been hearing in the media recently of this chronic hepatitis, is related to the cellular amplification of the immune response. And this study from 2020, you can see, suggests that the current main treatment method is thymosin alpha. This is the dose, this is the frequency. The course of treatment is 6 months. And the cytotoxic T lymphocytes are the effector cells in this treatment, and it's because of the effect of TA1 on T lymphocytes. There's a current phase 3 clinical trial with over 2,000 patients. This just came out again. If you can see 2020, it's not even in a journal yet. This is from clinicaltrials.gov. They're using interferon alpha nasal drops and TA1 just once a week in doctors and nurses. So one group is doctors and nurses working in the COVID-19 lab. The other group is doctors and nurses isolated in a COVID-19 ward in direct contact with those patients. And so this is currently ongoing, very exciting. The pharmacokinetics are studied here in many doses. It's rapidly absorbed. The peak serum levels are at approximately 2 hours. The dose proportional increase is seen. The serum levels return to baseline by 24 hours, and the half-life, as I mentioned, is about 2 hours. There's no evidence of accumulation after multiple subcutaneous doses. So if you give a dose and give a dose and give a dose, you're not accumulating doses. And so that's reassuring to know, like they gave the mice the 5 to 10 doses a day. So we know that even frequent dosing is not toxic except maybe to your wallet. This is excreted through the urine. Side effects, in fact, more than 3,000 patients with many diseases, it's well tolerated and no significant side effects. It's administered in children down to as young as 13 months and elderly patients up to 101, as well as patients with immunodeficiency. So they use it in decompensated liver disease, in renal disease, on hemodialysis, very, very, very well tolerated. And I can say that's true in my practice as well. General dosing guidelines, 1.6 milligrams injected twice weekly for 6 to 12 months. This is in a stable, this is your senolytic dose. This is your preventive therapy dose. If you're treating someone acutely with an autoimmune storm or with inflammatory bowel disease, I'm going to put these patients on once or twice a day until their symptoms or their blood markers improve, and then I'll wean them down to this twice a week as we go. That usually takes, you know, obviously it depends on the patient, but that usually takes 6 to 8 weeks for me to see a big change. So tell them, hang in there, do the daily or twice a day injections, especially in your sicker patients, in your preventive therapy, or your guy that's just looking to, how do I slow down this 60-year-old body from aging? The twice a week is your right on dose. And typically one vial will last you that full month if you're doing the twice a week dose at this rate. Here's some alternate dosing schedules. This is the Lyme allergy autoimmune, as I mentioned. The flu, if I see patients with flu, or what I've been doing to treat these coronavirus patients is I've been giving them 1.5 grams twice a day for 5 days, and then every day for 2 days. I give them the first dose in the office, and I show them how to self-administer. No one has any trouble giving themselves a shot if you show them how to do it. These are tiny little 31 gauge needles. I use an insulin syringe, the little orange ones that are the 50 microgram, or sorry, 50 unit insulin syringes. That's what I use, and they can self-administer, no problem. I usually will draw them up one by one and give them a bag with all of them in there. For ankylosing spondylitis, I give them a pretty big load, and then I give them a lower dose daily. Again, you're looking for symptom improvement as well as their markers to show improvement. And you'll see natural killer activity, CD count, CBC changes like that MEB I mentioned, IgG subclass should improve, viral load should improve. And like I mentioned before, many patients won't tolerate other therapies until you treat them with TA1 first. And so I use this in combination with lots of other peptides. I use it in combination with lots of other therapies, and a lot of patients won't be able to, some patients won't be able to lose weight until you treat them with TA1. So think about using this as your first line in a lot of patients. These are some patient cases. A 54-year-old white female with MS. She has frequent flares of MS, does not tolerate any of the medications. She has chronic fatigue, multiple food and chemical intolerance. I think she's down to something like 12 foods that she can eat. She has recurrent herpes virus as well, which completely complicates our picture. So I can't change her diet because any hint of arginine foods, and she has a herpes flare, which is extremely painful and not responsive to common valcyclovir. And so this was her treatment strategy. In fact, because of her very low tolerance, we started her with 0.1 milliliters of TA1, and she did that once a week for about, I don't remember, maybe a month before she went on to this schedule you see here. She has had no flares of her MS, but her herpes virus events persist. They are decreased in frequency, but she has had a few of those since despite being on the TA1. Amazingly, and you don't understand with this patient, no side effects. She has improved food tolerance, has been able to add a few foods back. So this is very exciting, and I think that actually speaks to her herpes virus flares. Because she's able to add some foods back, I know that she's getting a little bit more arginine, and she's still not getting quite the flares that she had before. So that's very exciting. We are adding BPC 157 because of her multiple food intolerance, and what I presume is increased intestinal permeability, and also because of her HSV outbreaks, we may be able to get some corral that as well. She is, by the way, sneaking TA1 to her elderly dog who has recurrent UTIs, and he has no flares or improved energy. This was about a year and a half ago, and unfortunately the dog has passed since then, but I don't attribute that to TA1. He was pretty old. I have a 33-year-old white female who has 2 years of chronic hives that was treated with prednisone, melatonin, Zyrtec, Singular, PERC cleanse. I don't know if you're familiar with that, vitamin C cleanse. All of these were ineffective. She had several other therapies. We gave her TA1 at this dose, and she had complete resolution of her hives. Pretty amazing. This is a 64-year-old nurse who had a bladder mesh procedure, bladder sling procedure, and general osteoarthritis that we related coincidentally to the bladder mesh placement. This resolved with testosterone pellet therapy and TA1 half a milliliter twice a week. Okay, so maybe coming up on one of my favorite therapies, pentosan polysulfate. It has it's a close second to TA1, which is why I wanted to put it second on the slide deck. It is FDA approved right now. It's an oral medication with anti-inflammatory and pro-chondrogenic properties. It does induce proliferation and chondrogenesis, meaning growth or stimulation of these baby chondrocytes into mature chondrocytes. So where you have damaged cartilage, we're seeing proliferation and growth of these cells. It's very exciting, and it's probably related to how pentasand polysulfate works on metalloproteinases and inhibiting the translocation of nuclear factor kappa beta into the cell. We know that nucleus. We know that this inflammatory chemical NFKB hangs around in the cell, just waiting for the right stimulation. And if there's the stimulation, something scary, infection, cancer, etc., damage, it will enter the nucleus of the cell and begin production of these inflammatory signaling molecules we've been talking about. And so we know that pentasand polysulfate inhibits that nuclear translocation. So very exciting that that's how it works. And these metalloproteinases are specifically involved in in the pathogenesis of osteoarthritis. We also know that it can be effective in benign prostatic hyperplasia because it has marked effects on the growth of smooth muscle cells. This is an Australian phase 2 clinical trial in osteoarthritis of the knee, showing improved knee function and pain reduction. And all of these patients not only had reported osteoarthritis or painful knees, they also had bone marrow lesions. And so we saw a change in the bone marrow lesion grade, volume, and area with use of pentasand polysulfate. They also measured activities of daily living, and these patients had improvement in those. 86.8% responded with a reduction in joint pain and improvement in knee function, 91% improvement in knee function. Not only did they show clinical improvement, which I primarily care about, they also showed bone marrow lesion size volume reductions, very impressive, just 2 weeks after the first injection, and this is suggesting actual regression of the osteoarthritis. So very exciting to me. This is actually my experience in my office. We use pentasand all the time for lots of things, as you'll see. In a human study in 2005, 114 patients, mostly women, which is interesting because that's not usually the case in studies. They were given 3 milligrams per kilogram per week for 4 weeks. The trial continuation was higher in the pentasand polysulfate group, meaning placebo group, pentasand polysulfate group. The patients who were in the pentasand group continued the pentasand because it was effective. The placebo group were more likely to stop the therapy. It improved the duration of joint stiffness and pain at rest for 20 weeks after stopping therapy. Very exciting, and has been my experience. Also significantly improved pain on walking and overall function for 8 weeks after cessation. There is a mild lowering of triglyceride levels, and I'm sure this is related to the general anti-inflammatory effects and metallomatrix protein. In 2010, similar study, only 20 patients, 6 weekly sub-Q injections of 2 milligrams per kilogram, quickly reduced swelling, improved clinical effects like flexion, pain with walking, pain with stairs, and that improvement lasted 1 year, even though they only got 6 weeks of therapy. Again, a mild triglyceride lowering effect. In allergic rhinitis, it inhibits, remember that nuclear factor kappa beta activation, it inhibits this process, which is anti-apoptosis. Remember, apoptosis is the programmed cell death, like packing up your house to move. It inhibits that whole process of dying cells. And so we can use this in allergic rhinitis because that's part of the disease state. It inhibits histamine release from mast cells, much like if you're familiar with the mechanism of action of montelukast. And it binds and neutralizes Th2 cytokines. So this is a guinea pig study. They gave pentasand polysulfate intranasally and had significant reduction in leukocyte, eosinophil, and neutrophil accumulation in the nasal cavity, and decreased anaphylactic reaction to the allergens. Very exciting. And I have a patient right now. I've just started her on this with pentosan polysulfate and a hyaluronic acid intranasally. And this is a patient who's had chronic cough for 13 years. She's in her 60s, and she just called me to refill her medication. So I can't believe, and I texted with her today, and she said, I'm seeing some improvement. I'm going to refill it. So this is the first thing we've tried on her that's been effective. So I'm super excited to see what happens next. I'll let you know. In cardiovascular disease, pentosan polysulfate attenuates, again, that programmed cell death, the packing up the house to move, and inflammation in the human diabetic kidney cells. We know that the diabetic kidney is most prone to disease. It suppresses the inflammation that is mediated by that nuclear factor kappa beta. You're going to hear these words over and over again. And the inflammasome, which you may have heard in the media talking about coronavirus. This is that inflammatory state that bypasses that organized apoptosis of the programmed cell death, the organized packing up, moving house. The inflammasome can stimulate what we call pyroptosis, which is this. Essentially, you're planning to move, and instead of packing up neatly, you just throw a bomb on your house, or you strike a match to your house and set it on fire. This pentosan polysulfate suppresses that whole process. It also functions with this metallomatrix proteins in reducing things like pulmonary vascular remodeling when it's exposed to chronic hypoxia in this pulmonary hypertension model. And in a rabbit aortic endothelium model, it regenerates aortic endothelium. Very cool. Some references there. So pentosan polysulfate also has some really good antiviral properties. And this Ross River virus is, I'll just give you a few examples. These are similar viruses to our current coronavirus, which is part of why I mention it, or mentioned these. In this Ross River virus, it causes epidemics of severe musculoskeletal disease. It has been circulating in the United States, and the symptom of this is crippling pain and inflammation of the joints, similar to rheumatoid arthritis. It can cause systemic bone loss and extensive inflammation. And so when we give these mice that were infected with Ross River virus, when we give them pentosan polysulfate, we had a decrease of 65% of clinical disease score. So that's pretty significant. And they did not really change their viral load, but their disease state. So again, talking about modulating the immune system, not necessarily killing the virus, but modulating the immune response, so you're not getting that auto amplification of the immune response, the cytotoxic signaling cells, signaling the next cell to produce its own cytotoxic chemicals in the next cell. So you have this continued amplification. Pentosan polysulfate aborts that continued amplification. They are highly potent and selective, specifically against enveloped viruses. They do this by shielding the positively charged sites, as you can see on that. This is the virus trying to attach to the membrane, and it inhibits viral entry, so it allows for immune clearance. Anti-HIV, when they studied multiple oligosaccharides like pentosan polysulfate, it was the most potent against HIV, and it was more than 10 times lower the anticoagulant effect than heparin. So if you're familiar with pentosan polysulfate, it is a heparin-like molecule, and we know that it has approximately 1/14.7 the anticoagulant effects of heparin. So I actually do use this in my my patients who are on anticoagulation with lots of caution. I will have a long conversation with them, and ideally with their significant family members, talking about the risks and talking about the benefits, and then we give a list of potential side effects and symptoms they should be looking for, and I check back in with them fairly frequently. If we feel like the possible benefits are there, then I'm going to go ahead and proceed with the therapy, even though there may be some downsides. I have a patient right now who's getting some significant knee osteoarthritis improvement, even though she has AFib and is on Coumadin. So we're, again, watching her levels of her INR fairly closely. She didn't tolerate the other anticoagulant therapies that are out there, and so we're watching her closely. And she currently had no symptoms of excessive anticoagulation. In human T-cell leukemia, another similar virus, these patients get this myelopathy and spastic paraparesis, and it specifically inhibits the viral particle production, and in a similar manner interferes with this envelope protein, as I mentioned before, which and then it also suppresses local inflammation. So again, inhibits the viral binding and then inhibits the local inflammation. It has sort of a 1-2 punch effect. It also has effects in influenza virus and respiratory syncytial virus by the similar steps. These are highly potent and selective, again, shielding that positively charged site. They also have an effect where they abolish that positively charged envelope glycoprotein, but they also add a negative potential, which also, so not only do they inhibit the site on the virus that binds to the cell, but they also almost propel the cell, negative, positive charge, propel the cell from the virus, preventing the interaction between the two. And so pentosan polysulfate has broad antiviral activities against enveloped viruses. In clinical trials of oral pentosan, these were terminated because of poor absorption, and oral administration may actually cause intestinal overgrowth of facultative bacilli in the colon and fecal flora, as well as histologic alterations in the intestinal mucosa. So because of my common treatment of patients with autoimmune or intestinal inflammatory diseases, I am not going to use the oral form of this drug. I'm going to use the sub-Q or IM version. And then there was a study with continuous IV use that patients developed toxic thrombocytopenia, which kind of makes sense with its heparin-like functions. So do be aware of that and follow their levels if you plan to use it in that way. I do not use it IV. This is your typical pentosan dose, approximately 200 milligrams twice a week for 5 weeks, then once a month for 6 months. That's what I do for most of my osteoarthritis patients. This is my prophylactic dose, the 2 milligrams per kilogram twice a week is my prophylactic dose currently for my patients exposed to coronavirus. And again, it does have the blood thinning effect. Maybe some hair loss, maybe some retinal damage, although that was with prolonged oral daily dosing only. In my practice, we have over 20 patients. I said 20 when I made these slides, but since I made the slides, there's more than that. All have at least 50% reduction in joint pain after 6 weeks of treatment, but the pain reduction begins around 2 to 3 weeks of treatment, and they have returned to activity. So this is very, very, very beneficial in patients. And we use it in combination with TB4 and BPC as well for general joint and bone maintenance in my athletes, aging athletes. In this 34-year-old white female with, this is a coronavirus case, we think, maybe, she had a history of asthma and eczema. She had coronavirus symptoms, fever of 104, I think it was 104, maybe 102.4, every single day, miserable, shortness of breath, cough, and this was the end of March. We gave her weekly pentosan 0.5, so this is my mistake slide. This is where I made a mistake. We gave her weekly pentosan 0.5 plus TA1 0.5 daily. In week 1, she had this respiratory and systemic symptoms that resolved by day number 4, but came back on day number 7. Remember, I dosed this weekly pentosan. We dosed the pentosan again, and again, her symptoms resolved by day number 4 and returned again on day number 7. So the last week we dosed it twice and her symptoms resolved completely. So this poor patient, although was not hospitalized, thankfully, did get relapsing symptoms, and I believe that's partially related to the weekly rather than twice weekly dosing of pentosan in this case. Thymosin beta-4, another super helpful peptide. This is a fairly large, and we're lucky that it's exactly 43 amino acids. Ryan can talk to you about that. It is found everywhere and in higher concentrations in damaged tissue. It is inside the nucleus. It is in the cytoplasm. It's in the serum. It's everywhere. This has been used for sports doping because of its ability to decrease injury time and reduce delayed onset muscle soreness. It definitely recovers athletes faster.